Thanks to APT. Thanks everyone for being here. My name is Pietro L. I work in Massy in France, close to Paris, and we will start talking about a little bit about calcified CTOs, of course, and what we need to succeed in calcified complex CTO, especially for relatively young operators like me, which the most important thing is to, of course, succeed, but to stick with your plan, to decide what is the material that you want to use, try to use your material as much as possible and be able to succeed the most. Of course, we all know what are the challenges in calcified CTOs. When it's calcified, it's more difficult to cross, with the wire. The wire crossing, wire tracking might be more complex. But then when we cross the wire, what we have to do, we need to pass a microcatheter, and we have to be able to pass material to pass the lesion and deliver all the systems we need up to the stent. So there's a few steps we need to start from the wire crossing up to the final shot that we need to think about, and we need to anticipate. We need to anticipate the problem. So wire crossing, wire tracking, of course, device crossability. Of course, without guiding support, we can do anything. And then sometimes we need calcium modification techniques in complex calcified CTOs. And in my presentation, very briefly, I will stick to the second and third item of this. So device crossability, what do we need to do once you pass your wire? And then how can we increase our guide catheter support? So when we're talking about uncrossable or difficult to cross lesions, we talk about lesions where we manage to pass the wire, but then we struggle to advance the microcatheter, to change material, to change the wire, to advance the balloon, etc., etc. And first step is we cross the wire. What we have to do, we need to pass the microcatheter. What are the characteristics of the perfect microcatheter? We have to keep in mind to think about, this is a calcified CTO, this is a calcified patient, this is a difficult patient. So what do we need to achieve to get a success? So perfect microcatheter, unfortunately, doesn't exist, but we need to think about the closest to perfect, and it has to be something which has good torque transmission. So we need to be able to rotate the microcatheter and to advance it in microchannels. It has to be pushable, but at the same time having low profile. We cannot always have the two characteristics at the same time. Sometimes we need taper tips, which can be able to can help us to start modifying the plaque a little bit. We need some rotation capability because it helps in advancing, especially in very calcified and tortuous long CTO. Of course, kink resistance, support for wire exchange, and some radiopacity. And that is why I'm relatively young operator. Relative, I say young, but I would say relatively young operator. So I decided to stick with not to change strategy, not to change material and devices every case I do. So that's why most of the times I start to use the microcatheters from the long family, which I think you're all familiar with in the APT medical family, because it helps me to get a good success rate, good, especially in calcified CTOs, but not only that. So we all know the young family, you have three different categories of microcatheter: the straight tip, the taper tip, which is the one which is preferentially used for calcified CTOs, and the dual lumen. I will try to explain why I use the taper tip in most of my cases, in calcified antegrade cases, but also in retrograde cases, because it's of its characteristics that makes it very easy to cross in tortuous lesion, but also in calcified lesions. We need to advance while rotating anticlockwise. It gives you very good pushability, very good trackability. You can see here in the video. It's due to, I will not stick to the all the engineering behind it, because it's not what I really need in doing my cases, but the fact that I use it most of the time, it's always giving me very good results, because it's very easy to torque. It's got good pushability. It's tapered, so it helps you advance in calcified, but also in fibrous CTOs. It's very well hydrophilic, and something I didn't add here, but it comes with a extension wire, which sometimes it can be very useful. So I will start with some cases which are, I think, quite interesting to show and to see why I started using this microcatheter for most cases. This is relatively short CTO, blunt stump, quite calcified, you can see here. Very nice epicardial collateral from left. So my plan was to start antegrade, and with the E-long 2.6. So because I thought it was calcified, it was a blunt stump, I needed some a taper tip to advance in the body of the CTO and a Gaia second. And you can see that with the support of the microcatheter, the Gaia could find some with some torque transmission. You can see here it advances a little bit, it crosses the cap, looks good in a good direction. And then what I did was to advance a little bit more, looked good, try to advance in the while doing the contralateral injection. The wire passed the lesion, so I was quite happy, but sometimes when you're happy you pass the wire, it was easy. Not all the time you are able to advance your microcatheter and do a problem, so and do your job, because that's the most important step. But you can see here the elongator with relatively easily it advances with anti-clockwise rotation. Don't need to push a lot. You wait and you let it advance a little bit, just doing anti-clockwise rotation. It passed the lesion quite easily, despite being quite calcified. It was short term, but it was not the most complex case to show, but it shows you why you can do this most of your cases, and this could have been a complex case if you had the bad material, and we managed to finish the case in a very short time with a good final result. The next is simple PCI, pre-dilatation, IVUS, and 3 stents up to the distal RCA. But as I said before, I started to use it also in retrograde cases. Maybe it's not recommended for retrograde cases because it's a 2.6 French, it's quite large, can be a little bit big, but so far no problem with septal. So you can see this was a little bit more complex case. It was a second attempt, and the first attempt was done in another center. They didn't manage, they dissected the vessel. We didn't really know what happened because we didn't have the film of the previous PCI. It's quite calcified all the way. The cap is quite ambiguous because we see here there's a small branch, but we don't really see we can imagine the trajectory of the vessel, but we don't really know where it goes. And we had very good septal connections. So my idea was to start very briefly antegrade, and if not, passing from retro and doing reverse cart. So here the wire was, we don't really know where, so we decided very quickly to go retro. You can see, despite presence of a stent here, the wire, this was a workhorse wire, sign blue wire, passed quite easily through the stent in the septal. You can see here. And the E-long follows very, very nicely. This is the same 2.6 French E-long. No problems in the septal. It crosses very easily through the struts of the stent without needing a pre-dilatation. And then, of course, we try to find a good septal connection with the Cyan Black. It was relatively easy. And unfortunately, I didn't register the old video of advancing it, but you can see the E-long arrived easily to the distal RCA. And then it's a relatively simple reverse cart setup. Knuckle, antegrade, and retro. We advanced a guide extension up to the mid RCA. Gaia second punctured the subintimal space and was able to, you can see here, re-enter in the guide extension there. Then we did a tip in. I didn't register this, but again, the result was good with no problems. It was a little bit of a stain in the septal, but that was probably due to some crossing of the wires. It was probably due to the Cyan Black wire, which took let's say, was not in the septal that we used for the retrograde approach. So think about it. You can use it antegrade, but you can also use it retrograde with no difficulty, not particular difficulties. What is good is when you have good pushability, the fact that it's tapered allows you to advance in septals. Of course, it doesn't have to be very small, but you can do it without big problems. And second issue you always have to think about when dealing with calcified CTOs is the support. Guide catheter support is mandatory, of course. And how can you increase the support? Of course, you can increase it with guide extension. The Expressman, I think you're all familiar with, it's got very nice characteristics of deliverability. It advanced very nicely. It's very, very well hydrophilic. Really, never have any problem with advancing it in the vessel. But also the good advantage is it's got 4 side holes. It allows you to work safely, to maintain perfusion in the coronary, which is the characteristics which is peculiar of the Expressman. This is in all the sizing from 4 French to 7 French. I almost always use the 6 French with no problems in CTOs and not CTO cases, because this helps you really during the case without having any problem, no ischemia, no ST changes. It makes it very easy. And I'll show you a case I did with the combination of the material we talked about so far. So this, you can see, was very calcified again, calcified nodule CTO, retrograde option. We can see there's not much. So we really wanted to achieve the case antegradely, and there's a lesion in the proximal part. So we took an elong again. I took an elong with an NERHP guide wire, which is a polymeric hydrophilic wire, which probably we'll talk about a little bit later in the presentation of my colleagues. You can see here with the support of the elong, I struggled a bit with the Fielder XT wire before, a Gladius wire, didn't manage, took the NERHP3. You can see that with the support, finds the channel. It was very nice. I think it's very nice to see how the wire behaves with some little bit of torque and rotation, just with the support of microcatheter. It manages to pass the lesion, and the micro crosses very easily, because at the end it was shorter than expected, but there was a big calcified nodule occluding the vessel. You can see it again here, crosses nicely. But then while doing pre-dilatation, patient had some chest pain. I was afraid to having dissected here. I was afraid to dissect and the dissection getting to the aorta. So I took a guide extension here, an Expressman 6 French. As you can see, it advances very, very, very smoothly with some anchoring balloon in the distal part of the RCA. No more problems. The 4 side holes getting perfusion in the artery. And then the case was done relatively easy with some pre-dilatation. We did some shockwave on the calcified nodule, and the result was good. You can see here the answer as well. So to conclude for me, of course, the harder the calcium, the harder the CTO, but the message I want to do, and the message I always say to myself, is stick to your plan. Try to use most of the time the same device you're familiar with. Try to use the good device for the good case, but when you need push, when you need support, when you're dealing with calcified CTOs, elong 2.6 French has become my microcatheter of choice, but also in retrograde cases, also in fibrous cases, in longer CTOs, almost never had any problem. Very, very good results. And the same thing is when you need to think about, of course, guide support is essential, but guide extension, it's very important. And when you're doing long cases with patients which might be suffering chest pain, ST changes, having the side holes is a really big advantage of this tool. And for younger, again, for operators like me, sticking to the same material is always a good choice. So thank you.